We're going to talk now about the effects of inhaled anesthetics on the vital system. In so doing, we're going to learn that the effects are more similar than they are dissimilar. But the dissimilarities, the differences between anesthetics, are vital to an appropriate use, the best use, of these wonderful agents that are part of our everyday life. We're going to first turn our attention to the effects of anesthetics on breathing. And note that all of the inhaled anesthetics are respiratory depressants. Now, how would you measure respiratory depression? What would you measure?
Increasing levels of CO2.
Increasing levels of CO2. So PCO2 is an important measure of depression of ventilation. What other index of ventilation is there that would indicate whether there's depression or not? PCO2, that's one of our prime ones. What else?
PO2.
PO2 might be. If we get a little closer on that, we might think in terms of saturation. And what would you use? How would you measure depression of ventilation as reflected in saturation?
Well, if the ventilation is depressed enough, you'll start to get desaturation.
Or turning it another way, if you got desaturation in a normal person, what should they do with their ventilation?
Increase it.
They should increase it. So the response to hypoxia is a measure of ventilation or ventilatory depression. Or the response to PCO2 increases. Does your PCO2 increase when you go running? You haven't looked, have you?
It shouldn't, because I should be breathing it out.
That's right. And in fact, it doesn't increase. Sometimes it even decreases a little bit. So you're metabolizing more, you're producing more CO2, but you're getting rid of it. The body has a fine control over the CO2 and does so by increasing ventilation in response to any increase in PCO2. So we can measure that, the increase in ventilation in response to increases in CO2, and use that as a measure of ventilation or ventilatory depression. We know that the potent inhaled anesthetics all increase arterial PCO2. That's shown here. Some do it a little more than others. Desflurane probably does it a little more than sevoflurane, although that difference isn't very great. But same as with isoflurane. Nitrous oxide seems to ameliorate some of the depressant effects of the desflurane. Nitrous oxide itself has very little effect on PCO2. In a pressure chamber at 1.5 atmospheres of nitrous oxide, no increase in PCO2 in volunteers. And we can measure the slope of the ventilatory response. How many liters per minute increase you get with each millimeter increase in PCO2. And there you really see there's no difference among the anesthetics. Desflurane, nitrous oxide, same as desflurane and oxygen, same as sevoflurane, same as isoflurane. They're all respiratory depressants. Where do you suppose you get apnea? Where does that curve tell you you get apnea?
Slightly less than 2 Mac.
It'd be less than 2 Mac. It's where on that curve?
1.5 to 2 Mac.
1.5 to 2 Mac. It's where these lines cross zero, isn't it? That's where you get apnea. That is indeed where you get apnea, where each of these anesthetics cause apnea. So the anesthetics are remarkably similar in terms of their effects on breathing, on the depression of respiration, and they're similarly similar in their effects on bronchomotor tone. What are their effects on bronchomotor tone? What do they do?
Relaxation.
Bronchodilators.
Bronchodilators. Say it louder.
Bronchodilators.
Right. You got to speak up. There's the illustration of the effect on bronchodilator tone, or bronchomotor tone. This is the percent of the control response of guinea pig tracheal rings to micromolar of acetylcholine. So you give acetylcholine to a bronchial ring, guinea pig tracheal ring, rather, and it constricts. And we give that a value of 100%. Then you add halothane or desflurane or sevoflurane, and the ring dilates, despite the continued presence of the acetylcholine, which would tend to cause constriction. What does that mean clinically? Where are these anesthetics useful? In what kind of patients?
Asthmatic.
In the asthmatic, or the patient with
COPD.
COPD. You bet. Well, let's see that in play.
Ms. Feld, I understand you have a history of asthma. Can you tell me how often you need to use your albuterol inhaler?
I usually use it about once a week.
Once a week? Okay. How bad is your asthma?
Well, it's ever present. I mean, I know when I have problems with it because I smoke, which I shouldn't.
Okay. Did you need your inhaler this morning?
Yeah, I always use it going into surgery. If nothing else, it's precautionary, but
Okay. Let me take a listen to your lungs. I'm going to get you to sit up for me. There you go. Open your mouth and take some deep breaths in and out. Again. Again. And one more. Okay, and come on, lean on back.
What do you hear?
She does have some wheezing, so we will give her a little bit more of the albuterol inhaler before we go back to the operating room. We're going to start giving you medication to help you go to sleep. It might sting just a little bit going in, but that will go away. Nice deep breaths. We're going to take good care of you. Susan, can you open your eyes? All right. Deep breath. Doing just fine. Just take a deep breath.
Okay.
Susan, can you open your eyes? All right.
You're going to use the brain technique, right?
Yes.
Okay. Tracy,
Yes, sir.
I'd go for it now. Oh, that sounds so good. Ah, sounds so good. Okay, I'm going to start your desk frame.
There's no wheezing.
There's no wheezing at all?
No wheezing at all.
We've had a patient who clearly had asthma in the holding area. Tell us how you managed this patient and have gotten to this place where we are right now.
Well, she took albuterol inhaler in the holding area. She had a few puffs of that. We brought her back to the operating room and anesthetized her airway by having her gargle with viscous lidocaine. And then we induced the patient after pre-oxygenation with propofol. She also received fentanyl and Versed. And after the propofol produced apnea in the patient, I inserted the LMA, and desferrine was turned on at 6%.
At a high flow.
At a high flow, that's correct. And she had,
Did you add any nitrous oxide to that?
yes, 50% nitrous oxide. And with induction, she's had no wheezing, and she currently has no wheezing.
So desferrine didn't precipitate any wheezing?
No, it did not.
What concentration of desferrine are you at?
Well, we are delivering 7% right now, and her end tidal is 4.6%.
And that 7% is now in a much lower flow rate than we started with, right?
Correct.
So we got a flow rate of what now?
We have a flow rate of about 1 liter now.
So we're doing pretty well?
She's doing really well now.
We're going to begin the procedure in a moment, and we may need to get to a deeper level of anesthesia. How much anesthetics do you think we could give her?
Well, her end tidal is at 5.5% now, and a MAC desferrine is 6.
Why don't we go up to 8%? So we need to turn the vaporizer, of course, at this low flow rate up to 14% or so. Good. Now let's see what happens with all the ventilation. We know we have a CO2 that is 41 and an end-tidal death rate of about 5%. Okay, we'll get that up to 8%. See what changes.
Okay.
Okay, we've gotten up to 8% by turning the desfrane concentration up. What can you tell me you see now?
Well, her end-tidal CO2 has gone up slightly.
To how
It's
high?
now at 47.
Okay,
And blood pressure has decreased,
okay.
now at 96 over 55. And her tidal volumes have also decreased.
So we've clearly depressed the breathing. But what about the chest? What about her wheezing? Has any of that come back?
Let me take a listen. She is not wheezing at all.
So we might actually have caused further bronchodilation by increasing the desfrane, but we can't tell because she wasn't wheezing at 6% or 5%, was she?
Right.
Okay. Sounds like she's doing very well.
She is doing well.
We have an illustration here of the fact that desfrane, despite its potential irritant qualities, does not precipitate or does not necessarily precipitate bronchospasm. It certainly didn't at concentrations less than 6%, and we wouldn't expect it to because it doesn't have irritant qualities there. But even when we went to 8%, there wasn't an issue of bronchoconstriction, at least as could be defined by wheezing. We also learned in this simple illustration that all patients will be susceptible to the respiratory depressant effects of desfrane or sevoflurane or isoflurane or halothane. All of them will show this increase in PCO2 with an increase in anesthetic concentration. Let's return to that issue of airway irritant qualities and remember this slide. It says give 2 Mac of desfrane, you get evidence of respiratory irritation. You also get it with isoflurane, but not quite as much. And with sevoflurane, you get nothing. But at 1 Mac, you get no evidence of respiratory irritation. They're all the same. And that applies broadly in terms of respiratory effects. We're going to see that using an LMA, it doesn't matter which anesthetic you choose in terms of respiratory effects because the concentrations that are used during maintenance of anesthesia, where we're talking about the use of the LMA, the concentrations that are used are all in the range like this that doesn't produce respiratory irritation. So the incidence of coughing, for example, in our patients who were given LMAs, and there were several of these, you'll see was 0. We didn't see any patients with coughing. The incidence, in fact, in various studies for desfrane and isoflurane and sevoflurane and propofol, it's all the same. It's all around 5%, 6%, 7%. And there's no difference among the anesthetics in the response of the airway with administration of anesthesia via an LMA. Let's see that again with this demonstration of induction of anesthesia with desfrane. Not with propofol, but induction of anesthesia with desfrane. Remember, we did that, did it nicely. James did a beautiful job.
Señora, voy a darte el carete. Okay. Y puedes respirar despacio y profundo. Es el oxígeno.
You have a nice mask fit. So we're inducing anesthesia with nitrous oxide and desfrane. The nitrous oxide is at about 60%.
60%.
Inspired and 45% entitled. The desfrane is at about 3%.
Señora, baja la mano. Respira profundo y despacio.
So we have a little excitement.
Just kind of reposition.
Yeah.
Slightly.
Pull the chin back a little more. We had got obstruction about 3 minutes into anesthesia. Maybe it was 2 minutes into anesthesia.
So she's
Same thing that we found in volunteers. You're given anywhere between 2 and 6% desperate.
Brief moment of excitement. That wasn't too bad in induction.
And in the volunteers, we could insert an airway without any problem. And in this patient, we could insert an airway without any problem.
Any language at all. Okay, we have now up to 56% nitrous and 3.8% desfrane. She is still obstructed. I think it's time to put an oral airway in. Can you do that?
Yes.
All right, you're going to have to be very quick. Can you do that?
Yes, sir.
All right, go for it. And now we've got a good end tidal reading, huh?
Much better movement of the bag as well.
Okay, so we are 4 minutes into the induction and at a level sufficiently deep to allow you to insert an oral airway.
Yes, sir.
Okay, it's just with desfrane nitrous oxide with some pre-medication with midazolam and a standard 100 micrograms of fentanyl. And that's all she's got. Now the desfrane's at 5.2%, and that is
Exhaled.
what kind of reading?
It's our exhaled.
It's an end tidal reading, isn't it? Does that mean her brain's at 5.2%?
If her alveolar concentration should be 5.2%,
So her brain would be there if it were at equilibrium.
if it were.
But we've only been going for 5 minutes, with the brain having a time constant of maybe 2 or 3 or 4 minutes. So we need 6 or 8 minutes before the brain will be at the concentration that we've got in the alveoli. So we're going to wait now for a full 10 minutes. And at that point, we'll see if we can get an LMA in without any other medication. You got to be quick again.
Okay.
Who thought this couldn't be done with desfrane?
I did.
Okay, we've been here for 10 minutes now. We've got an end tidal of desfrane at 5.4%. We've got the nitrous oxide at 50%. And you're going to now try and insert an LMA. You got to do it very quickly because as the gas went in quickly, as we developed an induction quickly, we can also lose it very quickly. Are you ready?
Yes, sir.
Okay. Remember, they said it couldn't be done.
Yes, sir.
All right, you're going to take this out, remove the oral airway. Okay. Let's just see if she'll breathe spontaneously there. And she's breathing spontaneously.
Spontaneous ventilation.
Good end tidal CO2. Okay. Who was it that said it couldn't be done? Okay. Just so we know. James, we put that laryngeal mask airway in. Tell me, was there any coughing at all?
No, sir. None at all.
Not one cough.
Not one.
That's pretty good.
Thank you, sir.
Okay. We did that for 5 days. As we put in LMAs, we had no coughing. We didn't have any coughing during maintenance of anesthesia with desfrane or with any of the anesthetics that we chose. Now, the irritant properties of inhaled anesthetics are an issue during induction of anesthesia, particularly for anesthetics like desfrane or, to a lesser extent, isoflurane, as we increase the concentration well into the anesthetic range. For desfrane, it's right at the border between the MAC, or at the MAC value of 6%. In recovery, should there be any problem with the irritant qualities of an anesthetic?
No.
No, because you're what?
Basically, you're going to be at a low enough MAC value when they start to wake up that it shouldn't affect the airway.
So no matter what anesthetic you use, you shouldn't be concerned about the irritant qualities of the anesthetic during recovery. But during recovery from anesthesia, patients will cough. And they'll cough sometimes violently and persistently as a response to a foreign body. Which anesthetics produce a greater susceptibility to that problem? Which ones?
Like desferrine, the ones that have the poor solubility because their patients are waking up faster, so they're more aware of the ET tube in or the LMA or anything like that.
Right. So the lower the solubility, the greater the potential for a problem during recovery from anesthesia. Can it occur with isoflurane? Can it occur with sevoflurane? You're nodding your head, but they can't hear that on the...
Oh, sorry. Yes, they can. Sorry.
They can. Well, let's see it.
Quinn, we're waking up our patient who's been given fentanyl roughly 2 mics per kilo, and we're waking up now from the sevoflurane. What do you notice?
Well, he's certainly a lot calmer than the last patient.
I still notice some coughing, though.
Right. I think that'll go away once we get the tube out.
Okay. Okay, slide that out. Chest is moving.
Coming back
Just
up.
maintain CPAP.
Yeah, we're coming back up.
Uh-huh. Quinn, looks like we've got a little laryngospasm.
I see that.
And we're overcoming that with some positive pressure. Hear a little bit of crowing right now. Donna, is he moving air?
Occasionally.
Okay.
So it's just as you said. It's with the poorly soluble anesthetics like desferrine, like sevoflurane, where the awakening is rapid and there is the perception of that foreign body in the airway, a perception which persists in the brain even though the foreign body is removed. And you saw that here. You saw that here. It can occur with the more soluble anesthetics, but it's less apt to occur. Why is that? Why is it less apt to occur? Go ahead, tell us.
I'm thinking, just because they're not waking up as quickly, or they're not aware of the presence.
That's right. They're at a deeper level of anesthesia, and they don't perceive that foreign body, at least with as much as they do with the less soluble anesthetics. What's hypoxic pulmonary vasoconstriction? What is it?
If you have one lung down in the case of a surgical procedure or even a pneumothorax, your body will shunt blood over to the lung that is effectively ventilating so that you don't have as much of a VQ mismatch.
So what's happening in the lung that's atelectatic?
You have decreased perfusion to that lung.
And that's because what happens? What happens in those vessels?
The vessels constrict and the
You've
blood
got
shunted over
constriction.
to the other side.
Hypoxic pulmonary vasoconstriction. That's it. They constrict normally. Why is that good?
Because you have less of a VQ mismatch.
So you've got protection against hypoxemia. What do the inhaled anesthetics do to that?
They minimally affect it.
They minimally affect it. And as you said, it's of particular relevance during one lung ventilation. This is an illustration of the effect of the three anesthetics that are of greatest concern to us on hypoxic pulmonary vasoconstriction as measured indirectly. This is the arterial PO2 before the institution of one lung ventilation. And this is time after the institution of one lung ventilation. You can see that the PO2 comes down by what looks like a large amount, by a couple of 100 millimeters of mercury, with desferrine or with isoflurane, with sevoflurane, all indistinguishable one from the other. But I say this is minimal. You said it was minimal. How can maybe 200, 300 millimeters of mercury be minimal? How can that be?
Well, if you have a PaO2 of 200, you still have 100% saturation.
Well, that's true.
So
but it's still 200 millimeters of mercury.
Right, but your PaO2 contributes a small part to your overall oxygenation. Your saturation would still be 100%.
Saturation would still be 100%. It reflects a very small change in what? What is it?
Oxygen delivery and oxygen content.
And oxygen content. That is, this difference changes the amount of oxygen that's dissolved, but that change is very small, very small. So that indeed suggests that the effects of the inhaled anesthetics, potent inhaled anesthetics on hypoxic pulmonary vasoconstriction would be very small.